Okay, good morning, good afternoon, everyone. It's 5 minutes past the hour, so let's begin. Welcome back to day 2 of the 6th annual partners meeting of the I strategy. We'll continue the great discussions that we began with yesterday. Just to go over a bit of what we saw yesterday, we had status updates from the region, from the I Secretariat and the various working groups of the I strategy. Colleagues shared important findings from the midterm evaluation, findings and recommendations actually. And we also heard from countries, the no regret countries in the last session. We also had a welcome address by Dr. Sosefal, who's the Assistant Director General of Emergency Response at WHO. And today we'll hear from other senior leadership from UNICEF and Gavi. That's how we'll begin, but we have a full agenda ahead of us. Just a little bit of housekeeping. We have interpretation available for you, interpretations available in English, French, Portuguese, Spanish, Arabic, and of course, English. You can choose your language from the bottom of the screen, and there are some instructions up available to us on your screens at the moment. Yesterday we ran out of time with our interpreters, so today I'll try to do a better job of sticking to the time limit. So expect to see me more, reminding you to hurry up. As yesterday, we'll be sharing the presentations and files with you. There'll be an online link that will be dropped into the chat box. So you should, all that important information will not be lost. And as usual, please do participate, send us your questions because the interaction is what makes this meeting. For those of you who will be speaking, so both speakers and if you raise your hand, once you're called upon, our colleague in the room, Matteo, he will unmute you so that you can speak. So just a little technical note there. And with that, I think we are ready to start. First up, we have sorry, my notes are all over the place, but we have an opening address from Gavi. It's a video from Aurelia Nguyen, who's the Chief Program Strategy Officer.
Good afternoon, and welcome to the second day of the I-Annuals Partners Meeting. Thank you for inviting me to join you today for these important discussions. As we reach the halfway point on our mission to eliminate yellow fever epidemics, I want to share with you our reflections on the journey so far. Since 2016, Gavi, the Vaccine Alliance, has committed more than 800 million for yellow fever vaccines, supported technical assistance through our partners, and provided additional funds for yellow fever diagnostics procurement and laboratory capacity strengthening. These recent investments in the expansion of yellow fever diagnostics capacity in Africa over the past 3 years have shown how improving diagnostics capacity can increase the public impact and improve the efficiency of immunization programs. And since the last annual partners meeting, we've seen countries make great strides against the disease. Uganda introduced yellow fever vaccine into the routine immunization program, the second of 4 high-risk countries that were close to doing so when the strategy was launched. And preventive mass vaccination campaigns continued in Nigeria, the Democratic Republic of the Congo, and the Republic of Congo, all while managing multiple challenges and competing priority in these countries. Let's talk about the challenges. The COVID-19 pandemic has led to declines in immunization coverage and continues to challenge health systems and services around the world. However, there is hope for recovery. The overall rate of decline in Gavi-supported countries slowed in 2021, while initial figures for January to May 2022 show a small increase in routine immunization coverage in lower income countries. The road to recovery will not be easy, so we must work together to dial up the urgency. Yellow fever vaccine routine coverage among Gavi-supported countries has remained stagnant since 2020 at 45%, still not fully to the level of 2019 and substantially lower than the ideal. Strong essential immunization remains the backbone of protecting the most vulnerable against yellow fever. As highlighted by a recent yellow fever outbreak in Guinea, it is important to close the gap and support high-risk countries that have yet to introduce, such as Ethiopia and South Sudan, as well as to identify and reach zero-dose children and missed communities in countries where yellow fever vaccine has already been introduced into the routine system. Over the past year, we've seen a resurgence of yellow fever outbreaks, resulting in 7 countries requesting doses from the global stockpile since the last annual partners meeting. Outbreak investigations and root cause analysis continue to be essential in order to tailor recovery strategies, as well as close immunity gaps through catch-up activities. The midterm evaluation of the I strategy provides a unique opportunity to not only recognize the success of this I partnership so far, but also identify ongoing challenges, course correct, and focus our efforts where they are most needed. In the remaining 4 years of the strategy, we will need to improve the way we target the most vulnerable and high-risk populations. We'll need to leverage other health interventions to amplify protection against yellow fever. And we'll need to engage a wider range of partners, such as civil society organizations, to benefit from their expertise, all while monitoring the potential risks of expansion of yellow fever transmission beyond the current at-risk areas. Gavi is committed to working in partnership to eliminate yellow fever epidemics, supporting countries to raise population immunity levels through strengthening essential immunization, preventive mass vaccination campaigns, and supporting timely detection and effective response to yellow fever outbreaks. Thank you for all your efforts in our collective fight to eliminate yellow fever thus far. I wish you the very best in the upcoming discussions and look forward to the outcome of the meeting, which will help us move towards the goals we set to achieve by 2026.
Thank you. That was the Chief Program Strategy Officer at Gavi. With that introduction, let's move into the first session of the day, where we hear from countries over the next half an hour. We have a few countries lined up for you. And we'll begin with Chad. We have a recorded interview with Antoinette Demien, who is the Deputy Coordinator of the Expanded Program on Immunization at the Ministry of Health of Chad.
L'année 2021 a été marquée par la survenue d'une épidémie de fièvre jaune au Tchad. Ça coïncidait avec des épidémies des autres pays frontaliers, notamment la République centrafricaine et le Cameroun. Le premier cas a été notifié et testé IgM positif au laboratoire national fièvre jaune de N'Djamena à la 38e semaine épidémiologique. Ce cas serait importé de la RCA. À ce jour, nous avons 2276 cas de fièvre suspect de fièvre jaune répartis dans 128 districts du pays, 73 cas de décès suspects enregistrés, dont 14 cette année en 2022. Dès la confirmation du cas IPD, une investigation multidisciplinaire a été faite et la riposte a dès lors été organisée. Nous avons réalisé une analyse de risque en novembre 2021, ainsi qu'un plan de réponse en novembre 2021. Nous avons aussi mis sur pied l'unité de gestion de l'épidémie de fièvre jaune en décembre 2021. Nous avons soumis 2 requêtes à l'ICG en janvier et en février 2022. Nous avons aussi réalisé une enquête entomologique de mars à mai dans plusieurs provinces du pays et nous avons également élaboré un plan de communication de risque. Les mesures qui ont été prises pour répondre à l'épidémie, nous avons soumis une requête à l'OMS pour un appui technique et financier. Et nous avons aussi soumis 2 requêtes à l'ICG et le fonctionnement aussi du comité de gestion de l'épidémie de la fièvre jaune. Nous avons conduit la riposte en 2 phases, c'est-à-dire en janvier et en juillet. Nous avons renforcé la surveillance épidémiologique, nous avons fait l'investigation des cas, nous avons renforcé aussi la capacité du laboratoire. Le processus de décision concernant la demande d'approbation des campagnes préventives de masse auprès des Gavi pour la mise en œuvre de la stratégie ACE. Nous avons fait l'analyse du risque a été fait et le pays a été placé en situation de risque élevé. Et l'élément qui a motivé le pays à demander à Gavi le financement d'une campagne de masse afin de protéger la population entière sont les suivantes. L'augmentation d'abord du taux d'attaque et du nombre de districts touchés, mais aussi la dispersion et la progression des cas vers les provinces du Nord, l'apparition des cas sporadiques tout au long de l'année. Ce que nous avons appris des moments difficiles et comment cela façonne nos plans pour l'avenir par rapport à la stratégie. Nos moments difficiles sont les moments de mobilisation de ressources pour répondre aux urgences sanitaires comme les épidémies de fièvre jaune et l'insuffisance de manque de financement et de vaccins en stock pour les urgences et les routines. Ce sont les points faibles de cette épidémie et ces aspects ont été planifiés dans le plan de 2022 à 2026. Les conseils qu'on peut donner à d'autres pays à haut risque de fièvre jaune par rapport à la mise en œuvre de la stratégie AIDS, c'est d'abord d'adhérer à la stratégie, ensuite d'élaborer un plan stratégique pluriannuel afin de mieux se préparer à répondre aux épidémies, et aussi renforcer la vaccination de routine et mener des campagnes de masse afin d'augmenter l'immunité collective pour espérer l'élimination des épidémies de fièvre jaune d'ici 2030. Nous avons besoin de la région africaine de soutien, surtout en appui technique et financier continu. Au niveau local, la mobilisation des partenaires locaux à la santé et l'engagement de toutes les parties prenantes. Au niveau international, c'est la mobilisation des moyens financiers pour les activités. Merci.
Thank you. That was the experience of Chad. I forgot to mention again that we might be switching between languages, so please feel free to choose the interpretation language that is best for you. Next, we'll be going to Ghana. We have the perspective from Ghana. We have Naziru Tanko Mohammed, who's a senior medical officer at the Ghana Health Service. And Ghana is special for us because it was one of the countries involved in the midterm evaluation. So we look forward to hearing about the implementation of the I strategy there.
Thank you. Thank you very much for the opportunity. Good morning, good afternoon to our colleagues. Thanks for the opportunity. We'll be sharing our experiences as a country on the implementation of the I strategy and responding to yellow fever outbreaks in Ghana. Next slide, please. So we'll go through an outline like this, set the background, share how Ghana was able to respond to the recent outbreaks quickly, the key lessons learned, and what do we anticipate into the future. We'll then zoom into the midterm evaluation of the I strategy and the next steps for Ghana and some general recommendations for other countries. Next slide, please. So just by way of background, Ghana is known to be endemic for yellow fever, and cases continue to be reported annually. These are interspersed with some focal outbreaks. As a country, we conducted selective yellow fever mass vaccination campaigns in response to outbreaks prior to its introduction in the routine immunization. But as it were, in 2010, we had the support of WHO to conduct a risk assessment across the country so that we'll identify the high risk districts, as it were. And it turned out that all the districts in Ghana were placed at high level risk. And so we began preventive mass vaccination campaigns in 2011 in a phased approach. And by 2020, all districts were covered. Next slide, please. So with the understanding of high immunity levels in country in 2021, 21st October, one of our regions, that is the Savannah Regional Health Directorate, received a notification from one of the districts in West Gunja of 3 suspected viral hemorrhagic fever. The laboratory in country, that is the Noguchi Memorial Institute for Medical Research and the National Public Health Reference Lab, supported in the testing of those samples and later confirmed at IP Dakar. So an outbreak started from an unvaccinated nomadic community in West Gunja, which the population there, or the nomads, were later found to have migrated from Nigeria. And the Ghana Health Service responded quickly by conducting 2 reactive campaigns. And the coverages for round 1 and 2, both were significantly high, 93.4% and 89% respectively. Post-campaign survey, 79% coverage as a country is what we recorded. Next slide. So see these subsequent slides is to give us some highlights on the epidemiology. In 2021, from the October to the end of the year, which is epic week 39 to 52, almost 869 suspected cases were picked, and we confirmed 166 involving 8 regions and 51 deaths. After the first round, we still recorded some cases, this time lower numbers in 2022. And as from January to November, for 2022, we've confirmed 13 cases involving 12 districts. Next slide, please. Yes, this is to show us some age and sex distribution, mainly the modal age being 5 to 14 years from January 2022 to November 2022. Next slide. And as we can see, the geographical distribution, the Savannah region was the main epicenter, as it were, with the deeper the red color. Then the surrounding regions, Upper West and Bono also recorded some cases. But for 2022, the cases have been low, as I indicated, just 13 cases confirmed so far, and just distributed across the various districts in the country. Next slide, please. And this shows us the epic curve as at the October 21st that we started the intervention. Most of the high cases, the numbers that we are recording subsequently after the vaccination campaign had been reduced significantly, and now only some focal cases that we are picking, which is really still a concern. We are responding to it, but in terms of the numbers, the campaign has really helped us bring it under control. Next slide, please. Yes, so how was Ghana able to respond so quickly to these outbreaks? I must say that the Ministry of Health, through the Ghana Health Service, commenced focal vaccination response prior to even the RCG approval by mobilizing local, available vaccines in country for us to start intervention in the Savannah region, which was the epicenter. There was effective collaboration with all partners, WHO, UNICEF, PAP, and JSI, all on board with the Ministry of Interior, all with their Central Health Command, all available. And just to bring some background, that all this was happening within the context that the COVID-19 pandemic was really at its peak in country, and the whole response was being led by the presidency. And so high level support and collaboration among all partners was very, very key and very supportive in helping us respond so quickly to the outbreak. And of course, leveraging on technology, virtual and hybrid planning meetings were held. Activities were integrated, leveraging on existing structures. As it were, our health workforce was up to the task already. We were deploying the COVID-19 vaccination. The same officers were going to use, and they were up to the task and were able to, in fact, in some of the regions where cases occurred and were responding, we're able to combine both the COVID-19 vaccination and the yellow fever campaign to run concurrently. Outbreak investigation was initiated at all levels. In other words, the district regions even started something before the national team got to the scene to offer their support. And the high level of support I mentioned for the outbreak was very, very key in this regard. And of course, responding to the multiple public health emergency, though very challenging, but officers and the management were all up to the task and offered the necessary support for us to respond accordingly. Next slide, please. The key lessons learned that integration of vaccination response to public health emergencies should be considered, though on case-by-case basis. As I indicated earlier, some regions were able to combine it, which worked very well for other regions, they were a bit skeptical and were not too sure how it was going to go. And so they still had to respond to the yellow fever outbreak separately from the COVID-19 response that we conducted. Delay in receiving confirmed results from IPD affects some, implementation of campaign response, as we also noticed. But in country, our National Public Reference Lab and the Noguchi Memorial Institute were very supportive. They were able to get us the test results in good time for us to start immediate actions. And so countries should be intentional in identifying and vaccinating people who are immigrants and may enter the country from unapproved routes, because the population that was involved with this outbreak that we responded to were nomads, and where they were staying quite remote in the forest and getting access to them, we had to use local and community structures to be able to get access to them. And so there must be some intentional steps to always ensure that newcomers or immigrants in country are reached before they serve as a focus where some of these epidemics may arise. Next slide. So our anticipation into the future, yes, we still anticipate there may be sporadic occurrences of cases of yellow fever in country. And there's the need for us to intensify our vector control efforts in addition to boosting our host population or their protection. Then also further research into the distribution and pattern of migration of reservoirs in country so that we can align our control and elimination efforts. Next slide, please. Yes, so coming to our midterm evaluation of the I strategy in country. The rationale of this exercise was to document the key lessons and best practices in our implementation of the actions, the key actions that we have identified for the period 2017 to 2022. And our focus actually revolved around the community engagement in the planning and implementation of yellow fever vaccination campaigns, then the tailored and targeted approaches to reach undeserved population with yellow fever vaccination, and integration of COVID-19 vaccination with the reactive yellow fever vaccination campaign. How all these interventions span out, or the lessons we could pick from them. At the end of the studies that was conducted, it came out clearly that the strong multi-partner collaboration and the wide engagement of communities and detailed planning were very key as enablers for the success of the preventive mass vaccination campaigns we conducted in 2018-2020. This is because right from the planning stages through to the implementation, our partners were on board: WHO, UNICEF, PATH, and CDC. Everybody was on board to offer us the necessary support. Then the communities were to engage, were also not left out. We engage them how best we can reach the target communities for these interventions. And enough time was actually put in place for us to get the planning detailed, and whatever we have was disseminated from the national level to the lower levels for everybody to be on board. Using the right community entry points was again very, very critical, or very, very key for our success story, because for instance, the nomads, they were not so much available for us easily. So we had to use the butchers and the cattle owners to be able to reach out to them, such that they felt that they were not actually being pursued for any bad reason, and then they made their families available for the interventions that we had. The role of the civil society organizations was also very, very critical, or very, very significant, especially in terms of social mobilization efforts at all levels. These CSOs and NGOs that we dealt with, or we are dealing with, have various officers or various members that operate at all the levels, and they stay within the communities. And so they know the people, they are able to interact with them. And the messages, there's that level of trust that was actually built between them. And so working through them, through the social mobilization efforts, most of our eligible or the target population understood the message and made themselves available for the vaccination efforts. So these are some of the key lessons that we would like to highlight and share with partners on this forum. Next slide, please.
If we can just wrap up quickly.
Yeah, so by way of wrapping up, thank you. Just to say that by way of our next steps, we would like to build capacity for our public health reference lab for the confirmatory test, and also strengthen the community-based surveillance for our communities. Next slide, please. So by our recommendations will be that countries should try and strengthen the routine surveillance through the community-based surveillance system. And then effective collaboration with all partners is usually very key. And of course, strong political support. Next slide, please. Thank you very much. And we are very grateful. Bye-bye.
Thank you. Lots of importance of partnerships and community there in your presentation. Thank you for that. Next up, we have Venezuela. We were meant to have an interview, but we will instead show a video displaying the work of PAHO and the Venezuelan Ministry of Health on yellow fever. And just before we start the video, just to let you know that we will have a Q&A session with the participants who are here. We were joined by Dr. Antoinette as well. So if you have questions for Chad, we have Ghana, other countries. So please keep them coming, the questions.
Venezuela es uno de los 13 países de América en donde la fiebre amarilla representa un problema de salud pública. El país tiene 3 corredores enzooticos naturales: el corredor de San Camilo, el corredor del sur del lago de Maracaibo y el corredor de Guayana. El mayor riesgo se produce cuando las personas no vacunadas entran en la selva, ya que pueden recibir picaduras de mosquitos infectados y contraer la enfermedad. Para prevenir la fiebre amarilla existe una vacuna que con una única dosis protege de por vida. Actualmente, la Organización Panamericana de la Salud mantiene un apoyo técnico permanente con el Ministerio de Salud de Venezuela para monitorear, prevenir y ofrecer respuestas inmediatas y efectivas contra la fiebre amarilla. Durante el año 2021, la OPS prestó apoyo técnico y logístico a las autoridades sanitarias de los 10 estados con alto riesgo de eventos y brotes de fiebre amarilla. También se apoyaron las acciones de vacunación de rutina y vigilancia epidemiológica en las demás entidades del país. En los próximos 4 años, gracias a un plan elaborado por la OPS y el Ministerio de Salud de Venezuela, se prevé ampliar esta cooperación por fases hasta cubrir todo el territorio nacional. En 2022 y 2023 se continuará con una segunda fase, en la que se llegará a los 9 estados de mediano riesgo y posteriormente los 5 estados de bajo riesgo frente a la fiebre amarilla, con lo que se espera proteger a toda la población del país. En respuesta al brote de fiebre amarilla reportado en el estado Monagas en septiembre de 2021, la OPS acompañó al Ministerio de Salud de Venezuela en la implementación de las siguientes actividades técnicas y operativas: capacitación para el manejo clínico y epidemiológico, análisis y vigilancia entomológica especializada y control de vectores, movilización y entrega de vacunas contra la fiebre amarilla, apoyo logístico para las actividades de vacunación con énfasis en las zonas de difícil acceso geográfico, fortalecimiento de la vigilancia de casos sospechosos de fiebre amarilla en humanos, desarrollo de un plan de respuesta hospitalaria para la atención de pacientes, monitoreo de primates no humanos para detectar con tiempo la circulación del virus, optimización de las comunicaciones para informar a la población, entrega de mosquiteros y donación de medicamentos. Todas estas acciones resultaron exitosas para controlar el brote y disminuir el riesgo de propagación hacia otros estados y países de la región. La Organización Panamericana de la Salud trabaja junto al Ministerio de Salud de Venezuela para que nadie se quede atrás.
Thank you for that. And now, staying in the same region, we're going to hear from Brazil. We have Dr. Ramos from the Ministry of Health of Brazil, who's going to talk to us about their experience. And Dr. Ramos, you have 10 minutes. I'd also like to remind participants that we're joined by Dr. Yamila Romer, who's online as well. So if you have questions on the presentation yesterday on Latin America and the Caribbean in general, please do drop those in as well. We'll have a Q&A session after this.
Thank you, Dr. Shagun. Um, hello, everybody. First of all, I'm glad to be here with all of you, hearing the experience of other countries. My name is Daniel Ramos. I'm an analyst for social policies. I'm here on behalf of the Brazilian Ministry of Health, designated by Dr. Cássio Peterka, who is our Director for Urbanization and Transmissible Diseases. I'll present the experiences of Brazil facing the largest yellow fever outbreaks of the last 90 years in the country. It is estimated that the burden of yellow fever in the Americas accounts for 8% of the cases worldwide. Of course, this is an average estimate. Actually, the burden oscillates over time and space, so from time to time, Brazil accounts for high proportions of cases reported annually. And recently, we reached about 60 or even 90% of the cases in the world. This makes Brazil the second largest producer of yellow fever cases in the 21st century, with 17% of yellow fever cases in the world and 72% of yellow fever cases reported in the Americas. This long case series shows the first documented cases of sylvatic transmission in Brazil in the 30s and the last cases of urban transmission in 1942. It shows also the yellow fever cases in primates in the more than 20 years of implementation of this strategy in the country. This is the main innovation in terms of surveillance in Brazil in the last decades. And this strategy contributed to prevent outbreaks and countless cases and death in Brazil. So in addition to the cases, the line shows the vaccine doses applied. It's interesting that the peaks coincide with the increase in the number of cases generally associated with the emergence of the virus outside the Amazon region, the endemic region. The last outbreak we had in the non-endemic areas resulted in the largest outbreaks we have seen in the last 90 years. As I mentioned, so in the last 7 years, we had more human cases in Brazil than in the previous 8 years, or the entire history of sylvatic transmission in the country. This is the more recent scenario. So we can see two different profiles in Brazil. So the first one is an endemic scenario. So cases in Amazon region represented in green on the map and also in green on the graph. We can see low numbers and a high frequency of occurrence of the disease in humans. So in the other area, what we call the extra Amazon region, we can see that the numbers are higher, reaching sometimes 1,000 cases, and the frequency is lower than in the endemic area. So we faced this reemergence from 2014, and we alert about the possibility of an emergence of yellow fever in the country. But in 2014, 2015, we saw chikungunya and Zika viruses emerging in Brazil. So they overshadowed in some extent the yellow fever alerts. And at that time, yellow fever did not seem to be a comparable problem to that caused by those arboviruses. So regarding this last reemergence in Brazil, the virus spread through the country from the Midwest region, uh, where we detect the yellow fever in a primate, a non-human primate, and after that, the virus spread through all the territory. The southeast region was seriously affected with thousands of cases and thousands of monkeys dead. So during this period, we confirmed 2,300 human cases of yellow fever and 800 deaths with a case fatality rate of 35%. We also confirmed 2,200 primates laboratory confirmed for yellow fever. Uh, it, it, Today, this virus that emerged in the Midwest region is circulating in the south region of Brazil. Um, but it's very interesting that a new, not new, but a distinct yellow fever virus lineage emerged in the Midwest from 2020 ahead. And so we now have two different reemergences of yellow fever occurring at the same time in the country. Uh, uh, all of this that we are seeing is not common to happen, but also it's not new. The routes of dispersal of the virus in Brazil are very well documented. So what we saw is that these routes tend to be repeated over the decades. So the difference now was the intensity of the transmission. Um, Facing this scenario, we pursued alternatives to reduce the impact of yellow fever on human populations. So together with partners from PAHO and from the subnational level in Brazil, we organized two meetings in 2018 on data modeling in order to recover some experience and some initiatives that were being developed independently and to identify potential contributions to the better understanding of the problem and to the adoption of effective control measures. We also established a working group called GRUNFA to converge initiatives and research projects to answer the main questions that we have involving yellow fever in the country. We use it from that time data from non-human primates to predict the occurrence of yellow fever in some areas and to prioritize areas for intensification of surveillance and immunization actions, since the occurrence of yellow fever in humans or in primates precedes the occurrence in humans. So we also adopt a new information system called SysGel to alert stakeholders about dead monkeys informed by the community specialists and health and environmental workers. This system works in real time, so it's very helpful for surveillance. Uh, the idea here is if surveillance services are sensitive enough, they will be able to detect cases in primates weeks or even months before human cases are reported and adopt timely prevention and control measures. The first product of this group, GRUNFA, was an action plan for our South region in which we detailed the strategy, the methods, and the outcomes of this effort. I'll let you have this presentation before, and I included some QR codes so you can access the documents that are related to each topic, okay? The result of this strategy was a massive reduction in the number of human cases, even in an area with low vaccination coverage and with high availability of virus in the environment, evidenced by almost 400 laboratory confirmed death of primates. So of these 17 human cases reported, almost all of them refused vaccination previously to the infection. We refined this strategy over the time and applied to other contexts and scenarios. In the Midwest region, the last we worked where a distinct yellow fever virus lineage emerged, no human cases were reported to date. We also have institutionalized this initiative within the National Contingency Plan. We provision for periodic updates of risk analysis and for preparation actions before the start of the seasonal period. Current immunization coverage at the subnational level reflects the new areas included in terms of vaccination recommendation induced by transmission in unaffected areas for 5, 6, or even 8 decades. During this period, 8 million doses of yellow fever vaccine were applied using different strategy depends on needs. We established plans for each of the Northeast states to increase vaccination coverage before these areas affected by outbreaks like those we have seen in Southeast and South regions. To conclude, the outbreaks are definitely a function of the low vaccination coverage, but also of the low sensitivity to detect yellow fever in primates, which has been shown to be a key element to reduce the risk for humans in Brazil. So it's important to highlight also the role of information system for the success of these policies and strategies. These are the main guidelines and protocols of yellow fever policies in Brazil. You can download them via the QR codes. I would like to thank you. Please contact us if you have any questions. Thank you very much.
Thank you for that presentation. That brings us to the end of the presentation section, but we can get to the questions. So please, Danielle, stay online, and I request the other country representatives to also turn on their camera. This will be an interactive session. So the first question comes from Maurice in the chat, and it's to our delegate from Chad, Dr. Antoinette. First, just appreciating your efforts, but also wondering about the reorganization of the national network of laboratories in the country. Dr. Antoinette Demien. Yes, could you speak again just to check the sound?
Oui, bonjour.
Bonjour, on vous entend très bien, allez-y.
Ah, est-ce possible de reprendre la question, s'il vous plaît? On vous entendait
Oui,
pas très bien.
c'était de Maurice dans le chat qui demande un update sur la réorganisation de... J'ai pas le français pour ça, mais the reorganization of the National Network of Laboratories. Vous avez compris? Sinon, je vais demander un de mes collègues francophones de... Ou j'imagine les interprètes, pardon.
Oui, j'entends l'interprétation en fait. Vous pouvez parler en anglais et puis l'interprétation.
Okay. Okay, good. The question is, how far are you in the reorganization of the National Network of Laboratories as initiated by the Ministry of Health recently?
Allô, vous m'entendez?
Maintenant, oui. Yes.
Voilà, concernant le laboratoire, actuellement, c'est en cours. C'était un plaidoyer pour transformer le laboratoire. Pour le moment, c'est encore en cours. Merci.
I think we're having some trouble. So maybe we go to Brazil, and then the minute Chad is ready to answer, just give us a heads up over the chat and we'll bring you in. So we have a question for Brazil, which was, what was the output of the midterm evaluation done in Brazil? Any outcome that was of interest to them? Dr. Ramos?
Yes, okay. So what we see today is a lower vaccination coverage in Brazil for all the vaccines. So we need to implement new strategies. Also, the new areas were included as pointed yesterday by Dr. Yamila, I believe, and these are the most populous municipalities in Brazil. So vaccination coverage are lower, but we included a lot of people in this denominator. So this is something to work, and we are working on that topic. We have plans with the main states that are newly included in the recommendation area. So we might be working for getting better coverage here in Brazil. It's clear that the background on vaccination coverage is key to prevent the outbreaks. I showed a graph that shows it in a very clear way. So maybe this is the main activity here. We are also trying to implement new strategies related to surveillance to timely detect yellow fever virus in primates. So the better use of these strategies helping to save people from the disease, and that's a key element to apply here in Brazil and maybe other countries in the Americas.
Thank you. Dr. Romer, would you like to add anything from the regional perspective? Yamila?
Hello. Yes,
We hear you. Hi.
okay. Yeah, I don't have too much to add to what the doctor said. I think the whole response in Brazil was a good example of what it should be done after an outbreak. It had very good results. Of course, as he mentioned, the denominator of the coverage rate increased sharply very abruptly. So that's the reason for the big gap. But in the last couple of years, we can see they got better every year. So I think that's our main goal now, to short that gap, immunological gap, and address all the accumulation of susceptibles in the last years. That is where the work is being done. Thank you.
Thank you. That was an interesting sound at the end. Maybe we'll try Chad again, Dr. Antoinette. The question on laboratory networks.
Oui.
Yes.
Vous m'entendez? Il y a un petit souci de connexion là.
We hear you. Okay, I think the problems continue. So I'll ask a question that came from one of our audience members. Is there any demographic analysis on the number of people affected by yellow fever in Ghana and Chad? So I'll invite the delegate from Ghana to start. That's Dr. Mohammed.
Yes, thank you. Thank you very much for the opportunity. Yes, so in Ghana, for the outbreak that occurred in 2021 in October, to the number of cases, that suspected cases were 869, and we confirmed 166. And these 166 had 23 or were distributed within 23 districts in 8 regions. There were 51 deaths at the end, making the case fatality almost 30.7%. But starting from January, from the episode week 1 to 47, that is up to November 2022, we've suspected 1,107 cases and confirmed 13 of them. And these are within 12 districts in 9 regions, but there are no deaths among these or so far this year. For the age distribution, we have an age range for the sex distribution from 2 months to 53 years, with the median age being 10 years. But the modal age for the affected individuals or the cases is 5 to 14 years. And geographically, it continues to be that the Savannah region, which is the epicenter, continue to be leading in the cases as we projected in our presentation, where the maps are showing really that the cases there are still leading. We have almost 128 of these cases or confirmed cases coming from the Savannah region. So those are the distribution of the cases epidemiologically as requested. Thank you, and over.
Thank you very much. We're unfortunately running out of time, but I see there's a number of questions in the chat. So I'm going to request participants to just maybe if you can answer them in the chat, especially one around the mosquito in Sao Paulo, what is known about its competence to transmit enzootic yellow fever. I hope I'm saying that right. So just a very interesting question. So please do have a look at those. But in the interest of time, let's move on to our next session, actually. It's a session that's going to be forward-looking. So we've heard a lot about what the last year has been, but this session begins looking at the future. So we have a video message from UNICEF, the Chief of Immunization, Dr. Ephraim. We'll go towards that now.
Good morning, good afternoon, good evening, colleagues, wherever you're calling from. It's a great pleasure for me to join you today virtually in this annual partners meeting. We at UNICEF are proud to be part of this critical partnership that is helping and supporting countries to advance their effort in eliminating yellow fever. And this partnership aims to provide global oversight, coordination, and support regions and countries for detecting and preventing yellow fever outbreaks. Since the inception of this partnership in 2017, over 200 million people have been protected against yellow fever in Africa. And this number is expected to reach about 247 million by the end of this year if all planned campaigns go as planned. The I partnership has been able to adapt swiftly and in effective ways despite the global challenge posed by COVID-19 related disruptions. And it's not only yellow fever, but the global disruption by COVID-19 and the restrictive measures have impacted the overall coverage of immunization. As some of you may have heard, and as immunization community members, a total of 25 million children have been missed from essential immunization, being under-vaccinated or unvaccinated in the year 2021. This is 2 million more than what we had in 2020, and 6 million more than what we had in 2019. This is to shed light on the fact that it's not only yellow fever, but also the other vaccine preventable diseases that the COVID-19 vaccination-related disruptions are impacting. And this offers another opportunity as the Immunization Agenda 2030 is attempting to make sure 2023 and forward is used as a year of recovery, a year where the immunization coverage will return back to pre-pandemic levels with a concerted effort of all partners. The I partnership has been able to adapt swiftly and in effective ways to avert the COVID-19 pandemic-related challenge and can use this opportunity to further this agenda going forward, as this recovery effort would mean reinitiation of new vaccine introductions and also expansion of restarting of campaigns that have been planned in the past. I am proud that we at UNICEF played a critical role in maintaining the delivery of yellow fever vaccines to countries who have been conducting campaigns and also introducing the vaccine. We were successful in our efforts to introduce yellow fever vaccine in countries for their national schedules in this year. I'm hopeful of us achieving this goal in Ethiopia and South Sudan, as well through our joint advocacy work, just like the way we did it in Uganda for this year. Together with our I partners, we are steadfast in advocating for sustained and improved routine immunization coverage to prevent yellow fever re-emergence, especially in West Africa, as we aim to eliminate yellow fever epidemic by 2026. These efforts, as I earlier stated, do complement the broader immunization strengthening effort and can make best use of the opportunities the recovery effort are availing. We must ensure that no one is left behind from the benefits of vaccination. Working together, we can protect over 1 billion people from yellow fever in Africa and in the Americas by 2026, as we have clearly outlined in our elimination plan. Yellow fever cannot be eradicated, but we do have the potential to eliminate the epidemic. Without the work of the eye partners, yellow fever has the potential to again lead to devastating epidemics with the international spread as we saw back in 2016. We cannot let that happen on our watch, and we have all the tools and the commitment and the means, and perhaps the strongest partnership in the immunization space to be able to be used to respond to this challenge. We at UNICEF know that working together is the only way to eliminate yellow fever epidemics, and we must work as one, and we owe it to our children to do so. UNICEF continues to be committed to the effort of this partnership. Thank you again, and I wish you have a wonderful deliberation and continuation of discussions. Thank you so much.
We have a presentation from Dr. Raman Velayudan, who's from the Global Arboviral Initiative, and he's going to speak to us about yellow fever within this initiative. Over to you, Raman.
Thank you very much. I would just like to have the first slide. Thank you. So basically, within the Global Arbovirus Initiative, this is just an update on where we stand today and how yellow fever perspective, we can draw a lot of parallels and work together. So as you all know, the Global Arbovirus Initiative is a cross-cutting activity within the organization, and there are more than 4 departments involved in it. Next slide, please. So this Global Arbovirus Initiative has got 6 pillars. I will go through one by one. Can we move on to the next one, please? So in the very first pillar, actually, I have given it a green shading mainly because some of these activities are ongoing with the limited funds. So we are looking at the drivers of transmission. We are looking at integrated data system and how we can have a global integrated dashboard, etc. So a lot of work is going on in those directions. But here, in terms of yellow fever, mapping risk and vulnerable areas would be very, very useful. Next slide, please. Moving on to reducing epidemic risk, again, there are a lot of activities where, first of all, the integrated surveillance is a great opportunity to work together. Cross-border exchange of information, especially in the 2 big continents of Africa and America. And then the vaccine to make sure that there is the high-risk areas are well covered. So these are 3 activities within this pillar where there is a lot of parallels with the activities of yellow fever. Next one, please. Now, next slide, please. So here there are activities which are actually we are not funding. There is no funds available on most of these activities, but there is great opportunity here mainly for vector surveillance and viral surveillance in vectors, environmental management of for vector control, and also again the cross-sectoral engagement. And then the most important one is urbanization and housing. Here also we have been working with partners on how to address this. There is a whole new initiative on urban health, and there is a lot of convergence here. Where we can have more efforts. Then the ultimate goal is to have really a sustainable vector control. Next one, please. So here, in terms of preventing the risk of further epidemic or pandemic, we really need to have a rapid reporting of risk, the greater community awareness, risk communication, and of course, the multi-sectoral partnership comes in. In terms of urban health, this is more important because when we are talking of urban vector control, there is a huge role for multi-sector partnership here because most of the urban administration is not within the ministries of health. Next one. Enhancing innovation and new approaches. There is a integrated research agenda, risk factors and role of, the burden estimation is important. There is also the role of social science, integrating preventive tools, and integrating our work within the One Health approach would be very important. So here again, there is a lot of convergence of activities, and we have avenues to work together. Next one. Partnership is very key, and as I said earlier, in terms of urban health, partnership is very, very important, because there is local city councils or city administrations which are very different from ministries of health. We have opportunities to partner private sector here, and especially in terms of enhanced surveillance and communication plan. Next one. There is a lot of parallels from the presentation I heard from Ghana and other countries. There's opportunities here of community engagement, of vector control, enhanced vector control, enhancing surveillance in the first place. And this is some of the key pillars of the WHO's global vector control response. And we are working on some of these activities, but there is opportunities to really make it more ideal for yellow fever response. Next one. So the key synergies are integration with urban health program, as I said, with multi-sectoral involvement, issues focused on empowering targeted groups. And here, what I mean by targeted groups are, in most of these programs, especially for AIDS control, we really need to target our efforts either on school children, women, etc. So these efforts have to be made, especially in urban areas, and there are opportunities to do that. Then, of course, tailoring deployment for preparedness, readiness, and response for outbreaks in priority settings, where again, there is a very important role for cross-border networking and collaboration. As I said, there is an opportunity to enhance our surveillance guideline document into a more user-friendly manual in the context of yellow fever and urban centers. We must remember that most of our entomological indicators for AIDS control are actually lessons learned from yellow fever. And we are just continuing to use them, and we have opportunities to refine it. At the end of the day, we also need a sustainable and resilient workforce in urban centers. Next one, please. So basically, to conclude, I really need to say that the threat of arbovirus will increase with rapid movement of people and good, urbanization and climate change. Enhanced real-time surveillance will be essential to prevent outbreaks. Vectors are continuing to get established in newer areas and expand to more countries. So we really need the surveillance to be agile. Prevention should be a priority wherever possible, and vector population should be kept at a very low level. Last but not least, I must say that there is a lot of lessons to be learned from the success story of yellow fever in the 60s and 70s, and we are still drawing on those, especially for vector control tools, which are ideal for implementation. Thank you very much.
Thank you, Dr. Raman. I can see from the chat lots of interest in vector control over the last 2 days. So if you have questions for him and our next speaker, Dr. Corinne Mell, please leave them in the chat, or you can raise your hand. We'll have a few minutes to ask them some questions later. So that brings me to Dr. Corinne Mell, who's a scientist at TDR, which is a special program for research and training in tropical diseases, who's going to talk to us about her work and how yellow fever fits in.
Thank you. Thank you very much. Thank you for inviting me to present today. So I will present on the TDR work on implementation research, but also about work we are doing in African country to prevent, detect, and respond to arboviral disease outbreak. Next slide. Just a bit of background about TDR, which is a special program in WHO. We have 3 units, one on research capacity strengthening, another one on global engagement, and another one on research for implementation. We have our separate board, and our focus is on research on poverty. Next slide. And could you, next slide? I think there is, yeah. When we speak about implementation research, actually is the research that goes after recommendation. So it's there is a strategy that is recommended to be put in place, but we don't know how to implement it in a certain country, or this strategy has been implemented and there are some gaps. So this type of research is looking at the reason why there is a disruption, and that will guide after the development of mitigation strategy, or it will pilot test strategy for optimizing health system service delivery. So most of the time, this type of implementation research project are mixed method study with qualitative and quantitative aspects. Next slide. When it comes to arboviral disease, we work together very closely with the WHO and TD department and the WHO regional office for Africa department for trying to understand what is the situation in Africa in terms of capacity for the country for the surveillance, but also the control of arboviral disease. So we developed together a survey that has been conducted in all the country of the African region, the WHO African region. 47 countries contributed out of 47, and the results have been shared in a meeting, in a regional meeting with all African countries. You see in the map at the bottom of the slide that there is an inadequate capacity in almost half of the country, either for surveillance or for control. There is only one country that could say that they have some capacity for addressing this threat. When we go into the detail of this survey, next slide. We try to define different dimensions: surveillance, control, vector control, community engagement. And if you, when we look at this, the score per dimension, you see that overall the capacity are less than 50% for all the African region, but also you see the dimension. When you look in more details, next slide. There are some activities on disease surveillance, diagnosis, case notification, and outbreak preparedness where there are more capacity, probably because of also the Ebola context in certain countries that help the country to put in place certain system for outbreak preparedness. Next slide. But there are certain area where there is really inadequate capacity in Africa. That is for the management of severe cases. That is for virological surveillance, entomological surveillance, vector control, and community engagement. These are really the key elements where more effort need to be done. And when I speak about arboviral disease, of course, yellow fever is inside. Next slide. So the next step for us at TDR is collaborating with the virtual colleagues and partners for addressing the identified gaps. Particularly, we are interested at TDR on community engagement in outbreak preparedness and response. So we'll try to build a project on enhancing behavioral and social communication in arboviral disease outbreak preparedness and response. Thank you.
Thank you for that presentation, Corinne. So now we open up the floor. If you have questions for Raman or for Corinne, please raise your hand or drop them in the chat. I'll start with one question for Raman, which is that we've heard a lot about the importance of vectors of the Aedes aegypti mosquito and the spread of yellow fever and other arboviruses. Could a little bit more be said about the changing distribution of vectors and implications for yellow fever transmission?
So basically, Aedes aegypti has adapted remarkably well to urban settings, and especially to live in and around human habitation. So what has happened in recent years is, with the warming of temperature in many countries, there is also another Aedes, which is Aedes albopictus. That in particular has spread to Europe, while aegypti is spreading to more countries in Asian region. The net result is today, when we start, before 1970, this mosquito was present in less than 10 countries. Today, it is present in over 150 countries. So it just shows the success of the species. The reason being that it can breed in any habitation, especially in and around the house, in small water containers. And the most unique feature is that their eggs can remain dry, maybe for a year if needed, and hatch as soon as it comes in contact with water. So this is a real robust feature of this mosquito, which really makes it successful in urban setting. And it is very, very difficult to eradicate it. So all we can do is to control, keep the population under check. So the temperature favors it, our environment favors it, and number three, it has got its own adaptation of having eggs which can hibernate or withstand desiccation.
Wow, that doesn't sound very reassuring, but I'm sure the good work of everybody here is keeping things in check. Corinne, could you tell us a little bit about how TDR works with member states? Maybe which member states, how do you interact with them?
Thank you. Actually, we are working, TDR is working with the WHO control program, but also with the National Disease Control Program. Most of the time, it depends on the disease, but for arboviral disease, the demand was coming from WHO HQ. On other topic, the demand is coming from National TB Program, for example, or Malaria Program, who are requesting our support because they have some problem in their strategy and they would like to conduct implementation research.
Thank you. I see that there continue to be questions for Dr. Ramos in the chat, but if you have any questions for our speakers in this session, please raise your hand. Otherwise, I think we're ready to move on. I'll give it a few more seconds if anybody has a question. After this, we're going to head into a little break of 15 minutes. And following that, we'll have, I'm being told it's 10 minutes. So that would be at, let's say if you're in Geneva, that would be 4:35. So just add 10 minutes roughly from wherever you are. Once we come back, we'll have a little video on the highlight reels of the Yellow Fever podcast. That should be very fun to watch. And after that, we'll have some group work, some brainstorming. So 10 minutes break and we'll see you soon. Thank you. Yeah, we're going to go to the video now.
Thanks so much for the opportunity to say a few words about the link between the I strategy and Immunization Agenda 2030, which is the worldwide global strategy for the decade on vaccines and immunizations. As you all know, IA 2030 lays out a framework that's relevant to all vaccine preventable diseases and provides the orientation for global priorities in the upcoming years through 2030. And embedded in IA 2030 and its approach is the specific mention of disease-specific initiatives, including for the global strategy for elimination of yellow fever epidemics, along with other initiatives like the measles and rubella partnership, certainly on polio, on COVID, and on meningitis. At the core of IA 2030 and the I strategy is the priority that everyone at risk is protected by full immunization, regardless of location, age, socioeconomic status, or gender-related barriers. And there's a really big opportunity for I to leverage the work and the innovations of the full vaccine program towards efforts like the approaches to missed opportunities for vaccination, approaches to zero-dose communities, children and families, as well as the really exciting work that's being done on use of digital technologies to enhance data and enhance the sharing of data for the benefit of full program optimization implementation. And this, of course, includes the data that is at the subnational and the sub-subnational level for identifying and accessing unvaccinated communities. So I wanted to just briefly show a couple of slides to assure that we're kind of all aligned on the agenda and what the IA 2030 really is all about. So IA 2030 has a strategic framework with 7 strategic priorities and 4 core principles for action. This is at the sort of highest top level, and you'll see within this really all the elements around what needs to happen for yellow fever vaccine in order for it to be fully deployed. This agenda, this strategy and vision was co-created over a period of years and has turned into a framework for action with implementation guides at each regional level, monitoring and evaluation framework, and an ownership and accountability framework. And then there is a partnership model, established bodies that together hold each other accountable and actually drive much of the sort of strategic direction of the implementation. And these are at the country level, at the regional level, and of course, an element at the global level. In terms of the goals, IA 2030 has stipulated and specified targets, quantitative targets, against each of the impact goals that are embedded in the vision statement. In particular, and you'll see target 1.1 is about saving 50 million future deaths from occurring over the course of this decade. And that includes the yellow fever deaths that should be prevented, can be prevented over the course of this decade. Now, on the 0-dose target, which was to reduce by 50% the number of 0-dose children over the course of the decade, we are far off track. In fact, there's been an increase of nearly 40% in the 0-dose children. And so we very much see 2023 as a year of advancement, recovery, and acceleration. Now, a lot of the way that IA 2030 sort of lives out the strategy is through the working groups. There are 8 technical strategic priority working groups, 4 technical cross-cutting working groups in orange, and 2 functional cross-cutting working groups. And you can see that I, as an active member of the disease-specific initiatives working group that brings together polio, measles, rubella, cholera, yellow fever, so that each of the initiatives, which themselves are actually working against all of the other areas, focus areas, are really drawing on the expertise that's found within the initiatives and not reinventing the wheel, not going it in a vertical way. So I wanted to speak a little bit also about the COVID recovery and the implications for the I strategy. Of course, there has been a marked resurgence of yellow fever cases in Western and Central Africa, and we really need to leverage the COVID-19 vaccination lessons and ways of working to assure that we're building from strength to strength and not simply returning to pre-COVID levels of coverage nor of ways of working. So we have many lessons that we've learned in the work together on COVID vaccination, and that includes both the introductions and the campaigns and the recovery efforts. And so those are all being embedded, stitched into the way forward with IA 2030. In terms of alignment and where there can be synergies to advance the yellow fever agenda and close immunity gaps to rapidly control the epidemic risk, I think there are several areas. First is on closing immunity gaps and achieving equity. And these efforts need to be made to ensure that community demand for yellow fever vaccination is strong and to extend the focus of yellow fever vaccination beyond infancy and across the life course. And that also means identifying and vaccinating unimmunized vulnerable groups. There are many efforts going on now, as I already spoke about, in terms of zero-dose children, which yellow fever also is benefiting from. I want to speak specifically about the supplementary immunization activities, the SIAs, that both are part of a yellow fever strategy and a part of measles, as well as polio and meningitis and other disease-specific initiatives. Sharing of information on unvaccinated communities, unmapped settlements, and other left out communities is really essential to do across initiatives. And we should not be going alone with a single antigen. I think this is a lesson that has been learned over and over again, is that communities want more than one intervention. Second is strengthening surveillance. And certainly the Gavi investment in yellow fever diagnostics to ensure that that diagnostic supply can be deployed to accelerate the identification of yellow fever. But that diagnostic strengthening is also leveraging and strengthening integrated vaccine preventable disease surveillance capacity to detect, investigate, and respond to outbreaks of all sorts. And then the third is around strengthening readiness and response. And I think we can't, I don't think anybody can have lived through these past 3 years without recognizing that immunization programs in countries are really at the heart of pandemic preparedness and response. And everything and anything that is done in order to strengthen the health workforce, to strengthen also the agility of programs to deploy, and certainly to extend the immunization program's self-definition of the age groups that immunization programs work with, to embed within primary healthcare services that adults also access: diabetes care, tuberculosis care, HIV care, non-communicable disease care, is really also a benefit for yellow fever vaccine strategies. So lastly, the key priorities for 2023, which really line up with what we are learning about from the midterm evaluation and the recommendations that have been made in the midterm evaluation, include things like IA 2030 is prioritizing 2023 as an acceleration year. It has prioritized getting back to at least 2019 coverage levels, recovering and accelerating the introductions of vaccines that have been paused, and operationally going in a much stronger way, an aligned, much stronger way as a set of partners to 20 prioritized countries, those countries with the highest burden of zero-dose children, in order to mobilize political advocacy, to unlock the resources that are already available, to align on technical cooperation and tailoring it to country needs, including the activities towards elimination of yellow fever epidemics in the endemic areas for yellow fever. This is about one team, one plan, one budget at the country level. It's about setting up a work agenda to better understand and address underlying causes of low vaccination rates, and particularly any gaps between measles-containing vaccine coverage and yellow fever-containing vaccines. Those gaps are often a result of supply stockouts, not programmatic reasons specifically, but there are examples where there are other programmatic reasons. And then the implementation of context-specific tailored interventions. And that is really about urban slums, hard-to-reach geographic areas, and specifically for yellow fever, mobile workers who are exposed to sylvatic transmission. Again, these are all areas of key priorities for IA 2030. So as we move forward, I think the way forward is about really leveraging the continued efforts of the whole of the vaccine programmatic areas of work for the benefit of yellow fever vaccine advancement and for the effective integration of that work with other vaccine preventable disease programs. And that includes vaccine preventable disease integrated surveillance and lab systems, the full introduction of yellow fever into national essential immunization programs, and carrying out the multi-antigen vaccination campaigns that will rapidly fill immunity gaps. It also means advocating for yellow fever surveillance and vaccine coverage, inclusion in primary healthcare information systems, which themselves allow for the use of and generation of high quality data, which we know is so essential to actually driving the quality and the impact of vaccine programs, including for yellow fever. So thanks so much for the opportunity to give a short briefing on where Immunization Agenda 2030 is at, the working groups, and how the yellow fever agenda is integrating and can leverage in an increasing way, going from strength to strength to advance the objectives of I. Thanks a lot.
Thank you for that video. I know this is such an important question for yellow fever, and we've been hearing some of these themes throughout, so it was really good to be able to listen to the full video. With that, we'll move on. We next are going to see a video of the best bits of the Yellow Fever podcast. And with that, our thanks go to all the experts who've contributed to this podcast, who've made it possible. Yes, on to the video.
As soon as we got the information, we were a little worried and we were afraid because these first cases were located in Kinshasa, and we said, wow, this great capital had more than 10 million inhabitants, and with this epidemic, we are really screwed.
This investment is really worth it, because when you have yellow fever outbreak in a country like in Angola, what happened? The entire economy will stop. People will stop traveling to the country because of the risk, and it will take years to catch back in terms of economic recovery. So you protect life, population, you protect the economy, and this is really what we need.
It's very important that we do everything we can to curb our emissions, to reduce the negative impacts of climate change, because a warming and less predictable climate combined with these poor environmental and health service conditions, that creates the perfect storm to make a large proportion of the world very vulnerable to outbreaks of these diseases.
Cities need to be a unit of intervention in our global control strategies for yellow fever and other arboviruses. The future is, I think, bleak if we don't. This is something that will affect people in the US, for example, I think, in the next 10 years. We, for example, saw things like Zika in South Florida and South Texas during the Zika outbreaks, which is a cousin of yellow fever in terms of in the virus tree. We also see dengue fever sometimes pop up, even in northern hemispheres. So I think we need to understand that what happens in the South will affect the North, and that also what happens in cities to a large degree will affect the world.
It's quite an exciting time. We have several innovations coming through. We should have good tools. It would also be, we have about 2 or 3 vaccine candidates in the pipeline, so that will also offer preventive protection to the part of the population. We also hope that in the near future, we will be in a position to have houses designed in such a way that it can prevent mosquitoes from entering the perimeter of the house. So we can design houses which are mosquito free.
Seeing people dying of yellow fever, preventable diseases, children, in secondary school, parents bringing out all they have just to ensure that this child doesn't die. And I know they will die because we did not vaccinate them at time. 2 stories in particular amongst many was getting into a village in Nigeria where a young girl, 15-year-old, which the father was doting on this girl and was ready to take whatever amount of money he had, just get me the drug to make sure my daughter doesn't die. But then the daughter died. And being there, you see yourself helpless. The other one was my own colleague, a doctor who trained in the University of Berlin, who should have gotten the yellow fever vaccine, but got the card. There are a lot of people who do that. They won't get the vaccine, but they go and get a fake card. And then he got infected himself. He died. And that was really another painful experience.
The system EUA that won this first prize of the European Innovation Council is using a lot of satellite data, providing a lot of information for the monitoring of the environment, for the changes of the ecosystem. Let's say assessing the changes, the climate, to understand how environmental changes and climate change is affecting the development of the pathogens, the transmission or the migration of mosquitoes, and the transmission of mosquito-borne diseases into new areas.
You have had a huge migration of people into remote areas that were previously forested that then become deforested, basically due to agriculture, but also logging, mining, these kinds of activities. So essentially you bring a lot of human beings into an area where they weren't before. And as you do that, you enhance the contact between humans and wildlife. So naturally that then leads to spillover events that we've been seeing all over the place.
All species of non-human primates on the Americas continent are susceptible to the yellow fever virus, especially those of the Alowata genus, which are the most sensitive. So when the monkeys get sick, they almost always die. This allows generating an early warning of viral circulation in the wild environment.
It's always deplorable to see people suffering or dying for a disease that we can prevent. In the case of yellow fever, only one dose of vaccine is sufficient and can protect for the life.
Some really gems there, gems of wisdom and experience. With that, I'll pass on to Rakhi, who's going to talk us through what's coming up next.
Hi, everybody. Good to see you all back here today. So I will hopefully try and explain this in a way that isn't going to be too confusing for everybody. Based on yesterday's midterm evaluation, we wanted to give you all the opportunity to discuss some of the recommendations in a bit more detail. So what we've done is we've created 3 different sessions that you can join. If you were an early bird and you managed to register this morning for a breakout room, you will automatically be moved to that room shortly. Don't worry if you haven't registered already, you will see some instructions on the screen. Group A stays in the main room. Group A will be talking about increasing political will, etc. Group B is going to look at governance structure, how it can be expanded and diversified. This session will be moderated by Cassandra Quintanilla, I hope I pronounced that properly. And we will have Group C, which is going to be moderated by Dr. Bassi from WHO Nigeria. In Group A will be Sally Ann Ohene from WHO Ghana. What I would invite you to now do is go to the bottom of your screen where you should see the button for the breakout rooms. If you can't see a button for your breakout rooms, move to the right-hand side of the screen where it says More and click on More, and you will be able to choose which room you go to. If you don't choose a room, you will stay in the main room for discussion on topic A. So I'll just give everyone a minute or so to choose their breakout rooms. Can you see breakout rooms at the bottom of your screen or a tab saying More?
There's a side that says Leave Breakout Room. Okay, I've seen.
Yes. So hopefully if you click on breakout rooms, you should be able to move to either B or C. If our moderators could come on screen, that would be helpful. Welcome to Dr. Bassi and Sally Ann, good to see you. Okay, I think we will have to begin those sessions now. Is everybody in for Group A? Dr. Bassi, I just checked Dr. Bassi is in Group C. If Dr. Bassi can't hear me, then he must be in Group C. Okay, over to you, Salian.
Okay, thank you. I hope you can hear me.
Yes, we can hear you.
Okay, thank you. So, good morning, good afternoon, good evening, colleagues. Hope you're all well. So this is Group A. My name is Sally Ann Ohene. I am at the Ghana Country Office, WHO. So welcome to the Group A session. And for Group A, we are going to discuss how to energize the I strategy for increased political will, renewed attention to yellow fever at all levels, business cases, high-level events, dissemination of common products. So you are welcome. Like I said, yesterday we had the opportunity to listen to the midterm evaluation findings. And one of the things that came up was realization that we need to really re-energize the I strategy. It looks like there's not enough political will, or there's not enough publicity about it, there's not enough attention. So how do we go about increasing the energy level? So this discussion is about us looking at various strategies and how we can do this. So it's an open discussion. Please feel free, if you have a point to make, please go ahead. Aki is taking notes, and afterwards at the plenary she'll present our discussion. So please let me know if you want to make a point, and we can hear you. Please feel free. And we are looking at different levels, at the country level, at the regional level, at the global level. Should we do a business case at country level? What should we do at the regional level? Should we do a relaunch, regional or global? Any ideas on how we can disseminate, the I strategy, production of communication products, podcasts, and so on? At the country level, how do you go about it? So please let me know if you have a point to make. Raise your hand, or you can come in, just unmute and make a point. So any suggestions? Anyone wants to start? So whilst we are waiting, I'll just maybe make some points. So when we talk of a business case, it's like you want to sell, something because of some key advantages or some benefits. So at the country level, what do you think? Anyone have a suggestion? How do we re-energize the I strategy? What do you think? Looking at where you're coming from or which level you are working at. Any suggestion?
Just looking to see if there's any hands raised. Please feel free to speak up.
Yes, colleagues, please speak up. This is about us and learning from our experiences. So please don't be shy.
Salian, did you have any initial thoughts?
Okay, so I think speaking from the Ghana experience, there are a lot of competing activities, lots of activities going on with COVID and other emergencies. So yellow fever is seen as one of the many public health emergencies ongoing in the country. However, I think from the meetings of the past 2 days, from the videos, we realized that a single vaccine can really help prevent a lot of heartache. Gift, I see your mic is unmuted. Would you like to come in?
Okay. I want to say something, but just go ahead when you're through.
Okay. So I was just going to say that we heard that just a single vaccine can prevent, this disease. And so there's a need to really promote it. I'll just halt there. You come and Gift. Afterwards, I'll just continue making my point. We are really interested in hearing from participants. So you come on and make your points. Later on, I can finish the point I wanted to make. So Gift, we are ready for you. Please unmute and make your point.
I'm in Kenya. My name is Gift Abiyo. Working as a yellow fever consultant in Kenya. I see a whole lot of political feel when it comes to implementation of some yellow fever strategies or a program. I just
They
like
had the conversation. We have to turn that down.
Can you hear me now?
Yes, Gift, we can hear you.
Okay. So I see a whole lot of political power that really plays around in Kenya when it comes to implementation of yellow fever activities. So it's actually getting me a bit worried when we are supposed to have really make progress. Now I want to give an example. Right, currently it's only 4 counties in Kenya that is implementing routine immunization for yellow fever. So I asked myself, what could have happened when we have 47 counties? What would have happened to other counties that they did not implement the routine immunization despite
So colleagues, please mute your mic. Please mute your mic. Please go ahead. Sorry.
So despite the fact that we have 47 counties, why is it that it's only 4 counties that is implementing this yellow fever immunization? So I get worried. And then also now we had an outbreak situation in 2 counties that have never immunized for yellow fever. Also, after that, we had some low coverage, and then we are also thinking of scaling up this yellow fever to other counties. We are trying to get.
Gift, how do you think this can be addressed? Because of time,
let me just wrap up. So we are thinking of how we can involve the political, the politicians, especially to buy in to see that yellow fever as a country and Kenya as a country is at risk. So how do we move forward in these activities to ensure that all the counties have introduced yellow fever into their immunization program? So one of the things I want to suggest, or I was trying to suggest to them, is maybe we could have maybe a national meeting or something that involves the key stakeholders, the decision makers at the national, who can really get to know what the risks that the country is at, and then push for risk analysis, and then introduction of yellow fever into these counties.
Okay, that's a great suggestion. Thank you so much, Kate, for your contribution. Right, Rashid, I see your hand is up. Can you please come on board? You can unmute and make your contribution. Thank you.
Okay, hello everyone. Good morning, good afternoon, and good evening. This is Mohib Rashid from Federal Minister of Health Sudan. I think to re-energize the eye strategies, we should group that the countries who are affected by the yellow fever and see to what extent that this country's level in this strategy. Some had this large mass vaccination campaign, some most of them already entered the yellow fever vaccines in the routine immunization. To build the business case, yeah, we have to record all the best practice or the lesson learned, who are doing well with adapting the strategies. What was the benefit for such countries? Because we are the country, we were suffering a lot from yellow fever outbreak in some provinces or states. Now, after for example, if I'm talking about Sudan, after completion of the preventive mass vaccination campaign from 9 months to 60 years, and now we are entering. So far, we are talking about for the last 7 years free of outbreaks. Now we look for more quality. What about the yellow fever surveillance and results? To see, I think the result of the evaluation and even the in-country or according to context can lead to what will be the basic for the business case, which can be generated at the regional level and shows the best practice. That over from my side. Thank you.
Thank you so much, Mawahib. Thanks for that contribution. So I think it's also related to what Gift said earlier on about an advocacy meeting, because in her country, Kenya, it's just 4 counties out of 47 that have yellow fever in their routine vaccination. So it looks like there needs to be some advocacy for the rest of the counties, and also even for, I guess, the Ministry of Health to recognize the importance of having yellow fever in the routine vaccination. He did mention that there was an outbreak, and so that is even more kind of evidence that can be put on the table at this advocacy meeting. So thanks to our 2 contributors for the suggestions. So Rema, have you captured Gift's point? She mentioned the advocacy. Okay, that's it at the second.
Yes, hoping
yes,
you can see it. Yeah.
Yes, I can see it now. Thanks so much. Yeah, so colleagues, Rema, how much time do we have so that we know how far we are going? Do you have an idea?
I think there is a counter somewhere telling us how long we have left, but I will just check. I think there was a point that Komaket or Blaise wanted to make.
Okay, sure. Let's hear your point, please. Please unmute.
Thank you. Thank you very much, Sally Ann, and thank you, colleagues. Good to join you in this discussion. I think I want to look at it from a WHO perspective, looking at the dynamics within WHO. I think that we have a lot of opportunity that we can leverage to increase the visibility of the eye strategy. For example, if you look at the way WHO supports countries when it comes to responding to health emergencies, WHO works very, very closely with health authorities in countries. So I think that we could exploit or leverage this comparative advantage of WHO, and also in coordinating, health partners to bring the agenda of yellow fever epidemic elimination in the forefront in countries. We could do this, for example, by drawing the attention of the WHO country representatives onto this very important issue. Even in the regional office, I think we could, reach the regional director and use her, the opportunities she has to increase the visibility of the eye, strategy. You know that since the the COVID pandemic, the regional director nearly always addresses a press conference every week on different health matters, COVID. Of course, COVID, dominated the press conference, but more recently, she addressed, for example, a press conference on the Ebola virus disease outbreak. So, I mean, these are opportunities that can be utilized. For example, we could advocate and have one of the press conferences focus on the, the risk and importance of, addressing yellow fever outbreak in the African region. So yes, I really want us to also look internally within WHO and exploit all opportunities available to increase the visibility of the eye strategy. Back to you, Sally Ann.
Okay.
Thanks.
Thanks so much. Thanks so much, William, for that brilliant contribution. Yes, we should look internally. So there are a number of avenues. And I think that, and there's a comment that the ICC must be put on board for the eye strategy implementation and expansion up to the private sector. So thank you, B. Deng, for making that comment. So yes, we should reach out, and I believe NGOs, FPSOs are also key allies that we can also bring in. What I particularly liked is the business, the case, because you want to bringing all stakeholders together to advocate. You want to make a case to sell to them the importance of the eye strategy, the dividends, the benefits that you get. And so it's really important. I think that's a key thing that we have to look at, how we can convince people that it's a great strategy, it gives you value for money. And with that, when we bring all partners on board, I think that it will go a long way to also publicize what has been done. The lessons that we've learned from other countries such as Sudan can be shared, the benefits. And I think that not only will we be publicizing, but we'll also be advocating so that countries that are lagging behind, as we've heard from Gift, will also see the benefits of coming on board. So colleagues, any other, I know we'll be running out of time soon, but if you still want to make a point, the opportunity is there to maybe contribute to the discussion. We had great input so far, but I think that if there's something you want to bring on board, it's very welcome. I think that it's a good investment, especially for routine immunization. Gifts, do you want to come back?
Yes, just to add up to what I've earlier said, I'm also thinking if we make if we showcase the benefits of this yellow fever vaccination, just like example from Sudan, I don't know, maybe sharing it in a global news, get someone to share in social media the benefits of this yellow fever vaccination. I think maybe it will help some countries to sit up to embrace the yellow fever, the eye strategies and all that. So I think because now social media has made information more accessible, And I think if we really spread our the good benefit of the eye strategies in social media, it can go a long way in making people get interested in the vaccination, and maybe also we can get the political will buy in there.
Thank you so much, Gift. Thank you for adding on. Are we back?
Hello? Hello?
Yes, yes.
Okay, so my name is Mimuna from Nigeria, Mimuna Hamisu. I just thought that if we could also make the yellow fever activity more visible around the port health, that would also make it more visible. For example, use of IAC materials, use of posters, that have information around yellow fever, because we know that at the port we have a lot of people going in and out of the country, and they tend to relate with what is happening around us. So I think it will also help us to, create more awareness and also pass the information that we need. Thank you.
Thank you so much.
Sally Ann.
Yes.
Hi, Sally Ann. I think we've come to time and everybody has joined us in the main room now, but thank you so much for your excellent facilitation. I was wondering if we could go first to Group B. So Jennifer, if you could share your screen, and Cassandra, would you be so kind as to repeat the topic and give us some of the discussion points? Thank you.
Why am I echoing?
Thank you so much to everybody that joined our group 2, actually. I don't know why it says 3. But basically, the topic was around governance. In particular, how could we expand and diversify the eye governance structure in order to include a larger range of stakeholders to fulfill the goals of the eye strategy. Our participants, with a limited time, we managed to bring up some interesting points. For example, the importance of cross-learning between the Americas and the African region, and how it would be better in order to do that to really engage country-level stakeholders, not just global-level stakeholders or regional-level stakeholders. And so there was this idea on whether we could do, for those specific discussions, bring out more country representatives from both the Americas and the Afro region to have those discussions and get those lessons learned. There was an example on the urban outbreak in Angola and how Brazil wanted to do this bilateral engagement to support and create some learnings. Another key item that came up as stakeholders was actually how to best engage academics, and how can we have a clearer path of engagement for academics and also for medical trainees, for example. So just to re-summarize, our working group was focused on identifying how can we best expand and diversify the eye governance structure. This, of course, trying to get all stakeholders involved and have a voice in the eye governance structure in order for better coordination and decision making. Some of the discussions that we had in our group was, first of all, how to best engage for a cross-learning between the Americas and the Afro region. So for that particular point, we thought that there's either currently there's regional and global representation in the different governance structures, but in order to better understand the cross-learning between regions, it should be also to include the country level perspective. And so it could be either as part of the governance bodies or as a specific working group when we're actually aim to tackle this cross-learning around specific subjects, for example, around outbreak response, urban risk, etc. Another key stakeholder that came up was academics, and it seems that it was not necessarily clear how academics can best engage with the eye strategy, even though there is some engagement in specific working groups, for example, the lab working group. It was flagged that it's not necessarily clear how can the learnings, for example, on ongoing and future research can be disseminated. And so that's also a gap that we need to consider and think about and make it clear as well for the whole community on how to best engage and shape the I strategy. Similar to that, there was also that another community, which is all medical students, for example. Since we recognize that yellow fever is a global issue, how can we engage medical students as part of the advocacy efforts so we can all try to work together and create this advocacy for future reference? Thanks.
Thank you so much, Cassandra. I'll now actually just go to the group that I was in with Sally Ann. So Sally Ann, I will share our outputs if you wouldn't mind giving the group a summary of what we discussed. Over to you.
Okay, thank you. Hope you can hear me. So thank you very much, all our participants and contributors. So a number of suggestions on how to re-energize the I strategy came up. One suggestion was that the countries that are affected by YF should be grouped and build a business case, share best practices and lessons learned. So for example, Sudan had a very successful journey as far as yellow fever is concerned, to document the lessons and to share with other countries so that they would also learn from Sudan's example. Another suggestion was that we should have high-level advocacy meeting involving or multiple countries so that stakeholders in countries that are lagging behind and having national yellow fever routine immunization programs can learn from other countries. We had the example of one country where only 4 out of their 47 countries were providing routine yellow fever vaccination, and there was an outbreak in one of the counties. So to learn from other stakeholders about how cost-effective it would be to have a national program across all countries. And then also, there was also a suggestion that we really needed to, as WHO, really take all opportunities to highlight the I strategy. And so, for example, there's the RD's press conference, and to highlight the advantages and benefits of implementing the I strategy. So we need to do more. We need to leverage the WHO country reps in the countries to highlight the I strategy and use all available WHO platforms and networks. Then there was also the suggestion that the ICC must be put on board for the I strategy and also to leverage the private sector. So building that business case is really important because it's like you sell the idea of having the I strategy. And once people see the advantage and the benefits, they are more likely to buy in, to have that ownership at the different levels. So I believe this sums up our discussion at our group in Group A. Thank you all very much for your support and contribution. Over.
Thank you so much, Sally Ann. And now we'll go to our final group. So if you could put your outputs up on screen, please. And Dr. Bassi, are you there?
Yes.
Hi, Dr. Bassi. I'll let you
I'm
summarize
here.
for the. Okay, great. I'll let you summarize for us the outputs of your discussion.
You can see the slides.
Yes, we can see the slides.
Okay, thank you. Our group look at ways we can improve services to underserved and high-risk populations in society. And a Nigerian example came to bear where we have what we call the zero-dose strategy, where we are able to triangulate where we have zero-dose children to the settlement levels, and we focus on those zero-dose children when we do activities, we integrate intensified routine immunization services to enable us get to where those zero dose children is, which requires planning to break the barriers that hitherto exist that do not allow us to get to those zero dose children. So in the process of planning for any activity, routine immunization, non-polio SIA, polio SIA, we incorporate this activity into it to enable us reach those children to deplete the number of children who hitherto have not been vaccinated. It was also brought out that we can share information among programs. And when we share information among programs, we will be able to leverage on what each program is doing, and we can better position services so that these services can be beneficial to areas where hitherto services are not being taken to. Then we were told also from the group that we can conduct a comprehensive mapping of the underserved population. And when we are able to identify where these populations are, we'll be able to use it to plan, we'll be able to use it to implement, and we'll be able to use it to deliver services to them, and then prioritize what activities we are going to take to them to enable them get those services that in the past they are not able to get. And we are also discuss the area of operational research. We will be able to get at what are the factors or the facilitators of barriers to access to care. And from the operational research, we're able to get those factors and we can use it now to drive the program. We also talked about how to fix the valid source to get exact information, real numbers and gap in the area of vaccination, and the other things we do to enable us to provide access to people in this group. And we look at insecurity as one of the reasons for access to people, to those communities. What can we do to go around insecurity and enable us deliver service to these people? So insecurity was seen as a major factor. Staff attrition was also seen as a major factor. We train people today, we recruit people today, tomorrow they leave for other services, and we lose them in the process. And this we have seen in this our group. So briefly, those were the areas the group focused on. Thank you, and over.
Thank you so much, Dr. Bassi. Thank you so much to all of our moderators, particularly the last minute stand-ins. Cassandra, that's much appreciated. Just so you know, all of these inputs and great points raised by all of our participants will be fed into ongoing discussions that are happening in the coming weeks, talking about the midterm recommendations and how we will be implementing them at various levels going forward. So I'd like to thank you all for your contributions. Apologies again for some of the technical issues we're managing to power through. Over to you, Shogun, for our final presentation of the day. Thank you.
Thank you, Raki. That looked like a very fraught and interesting session. So before we continue, we'd just like your feedback on this meeting, what you enjoyed, what could be done better, maybe some words of appreciation for our organizers. There's a link up on your screen, and it'll also be shared in the chat. It's a short survey of 6 questions, and it should take you no more than 5 minutes. So if you could just do that right now, we would really appreciate it. Can somebody drop the link in the chat? There you go. You have the link to the survey. So if you could just take 5 minutes, we can meet back at In Geneva at 41, 5:41. And after this, we'll have a summary presentation by Laurence from the I Secretariat. So stay tuned for that. We see that some people have already responded, but if you're having trouble, don't hesitate to ask us. It's just 6 short questions that will help improve this meeting for next year. Okay, I understand that it's a bit more technically complicated. We need everybody on there right now because we can't proceed to the next question unless everyone's answered the first one. So if you could please request everyone to get onto the Slido link right away, that would be great. Okay, thank you. Thank you to everyone who responded. And to those who didn't, you still have a few minutes while Laurence is presenting to multitask and answer the survey. So with that, we'll go to the presentation from Laurence, who's going to speak to us about what we just spoke about. So she's going to summarize the meeting for us. Over to you.
Okay, so I guess as we wait for the presentation to come up, what I really want to say are not a full summary, but mostly words of appreciation for everybody. I've been very impressed by the work presenting during the 2 days of these meetings with interventions from countries, from Africa and the Americas, from NGOs, from regional colleagues, and from global partners existing and potential. I really want to thank the up to 155 participants to this 6th annual partners meeting on the I strategy. It's very meaningful, I think, for a program to create a forum where stakeholders from the Americas, from Africa and Europe can engage and share experiences. I want to thank all of you for your engagement in the global strategy to eliminate yellow fever epidemics. I also want to reiterate my appreciation for the efforts and the achievements on the road to the elimination of yellow fever outbreaks. We are indeed all stewards of the I strategy, and I do look forward to the next meeting that will be able to hold in person with the kind of affluence and engagement that you see on these slides. And these are good souvenirs, I must say. Next slide, please. The strategy is indeed in a critical phase. Last year, we talked about entering this phase. We're very much into it now, as we heard yesterday. And I'm really proud to say that despite a pandemic, we are en route to achieve the vaccination milestones that we had set at our inception in 2017. Next slide, please. But we also have emerging issues, and primarily the resurgence of yellow fever outbreaks in areas with history of large-scale prevention campaigns, with urban risk, and we heard about this today, and potential to threaten global health security. These emerging risks have the potential to reshape our work and approaches over the remainder half of the strategy, and they do need addressing. Next slide, please. The independent midterm evaluation that we undertook as a partnership, and I want to reiterate my appreciations for all those who provided insight and materials. So this midterm evaluation will provide useful guidance on the way forward and the further enhancements needed in our ways of working, our approaches, our networks for greater impact and sustainability. As we heard from colleagues, from partners, from leaders, there are important opportunities that can be leveraged and joined towards ensuring that our needs are met. We don't need to reinvent the wheel. There are specific aspects that only us can address, but there are also many things that we can do together. And this is particularly important in some areas that we've discussed around urban risks and spread, to reach migrant and vulnerable populations, to close immunity gaps and ensure equity. We've heard concrete opportunities from the Immunization Agenda 2030, from the Global Arbovirus Initiatives and One Health, potential opportunities with the work on poverty disease, on operational implementation, research and training, and interesting insight and perspective from the flagship programs in the emergency group in Afro. There were also really powerful interventions that I want to appreciate with concrete examples of integration at country level, demonstrating that this is indeed feasible. I also appreciated the very rich feedback and propositions from the working group that we just heard, and how to re-energize and expand and diversify our partnership and improve impact. While we also continue to work on innovations, particularly through engagement with the private sector, but that was mentioned by the working groups as well, and the extracting industries to protect high-risk workers and their families, prevent introduction into urban setting, and as such also prevent international spread. I've taken very good note of the importance to develop country business cases. Thank you very much for that proposition today. I think that was also mentioned by the team working on the midterm evaluation of the strategy. I think, in other words, the future belongs to us. We'll continue to work on the recommendations from the midterm evaluation, to prioritize them. That would be a very important exercise, and then to put them into action, another challenge, but important one to take on, and continue the line or string of successes that we've had. A last word of appreciation and admiration to countries. You are leading the charge, and that's critical to ensure that existing mechanisms and initiatives are indeed leveraged to protect at-risk populations, prevent international spread, and respond to outbreaks quickly. And I really want to take on the suggestions for the I strategy to further cross-country collaboration and peer-to-peer learning. I think that's an idea, a theme that we've socialized before, but I think that's been really reinforced in today's discussion. And thank you very much for that. And it's something that we'll keep in mind and as a priority as we rethink some of our work moving forward. So with that, I'll be closing the meeting. I want to reiterate my appreciation and thanks for your engagement and partnership. And closer to me today in the room, I really want to appreciate our MC, our partners, and I have Gavi next to me. Afro is connected online. I want to appreciate our TDR colleagues, tropical disease research colleagues who joined us today and with whom I hope to work further. And of course, the I Secretariat and all the colleagues behind the scene, without whom that would not have been possible. So for all of us in the group, if you could please, including Matteo, just put your speaker on, say a word, and your face will come to the screen. I think it would be helpful for people to understand who you are, as you've done so much for the success of this meeting. So thank you very much, colleague. I'll be closing my speaker. Others, please. It would be wonderful for people to get to know you. Thanks very much, and good meeting.
Well, hello everyone. I'll do the first.
Well, hello everyone. Thank you, Laurent. Thank you to all the team, and thank you for your participation.
Hi, everybody. Most of you know me because I've been hassling you, sending emails, chasing things for the last few weeks and months. I just want to say thank you to all my team, my co-workers, colleagues and partners who've been helping to pull this together. It's a huge effort that takes about 4 months in planning. And so although I'm a little bit disappointed with some of the technical issues, I really hope it hasn't detracted from your enjoyment of the event. And we really appreciate you making time to prioritize yellow fever amongst all your other priorities. So see you again this time next year. Thanks.
Hello, everyone. Thank you for your patience and keep up a great job that you're doing. Thank you.
So Kelly, Ronan has left the room, but I think all of you know but she's been a pillar of the work we've been doing over the last 6 years. Thanks again, colleagues. Thank you again, partners. Thanks, everybody. Jen, we haven't heard you. Please do so. I won't let you go with this.
So, oh, I get, do I have? Okay, the camera's going to come in on me. So yeah, so thanks everyone. I think I'm a familiar face to most people, but for those who I'm not, my name is Jennifer Horton. I'm a technical officer with the team. And it's been a pleasure to be part of the discussions and the excellent presentations and this very fruitful annual partners meeting. And I'm also going to just steal this little moment and also give a shout out of great thanks to the IMST. And I hope that they are online right now, but thank you guys, because you've been an excellent part, instrumental to the coordination and response in Africa over the last year, really. So thanks to our regional colleagues and especially to the IMST. Thanks, over.
Marie-Ève.
Well, thank you everyone for being here and for your participation, and everybody's making a small or larger contribution depending on the time you're spending working on the eye strategies. So I wish you well, everyone. Thanks.
Very much. We'll see you soon.